Hello, good morning everyone. Today we are going to start with the Starling curves. So yesterday we understood the Frank-Starling law. Today we are going to understand the Starling curve in details. So writing it out, Starling curve. Now before going into details into the Starling curve, let's remember what actually the Starling curve wants to show us, wants to tell. So, what is the implications? The implications of Starling curve is the theory that we studied as in Frank-Starling law. So, Starling curve actually it shows us that whenever there is an increase in the preload. Preload means preload is nothing but the end diastolic volume, the volume of the blood that is in the ventricle after the filling phase, both passive filling and active filling. So whenever there is increase in the preload, very simply we can remember the heart pumps more blood. That is our cardiac output. Stroke volume, then cardiac output. This is the first thing it says. Second implication is of the Starling law. The second implication is that if the force of contraction increases, then also the heart pumps more blood. Okay, now these two things we will understand with the graph. Going to the graph, the two axes we draw are like this. On the x-axis, we have our end diastolic volume. End diastolic volume means what? It also means the preload. It also implies the preload. And on the y-axis, we have the stroke volume or the cardiac output. So, in normal condition, under normal physiological condition, the Starling curve looks something like this. Okay, that means at a certain given preload, the force of contraction is such that there is a specific stroke volume that is attained. Now, let's think that this is the normal point. This N, it is the normal point at which the heart is pumping certain amount of stroke volume at a given end diastolic volume or at a given preload. Now, if we alter the situation and it happens to be like this. Now, suppose this is like a preload. Suppose the preload is increased. There is a increase in the preload. Now, when there is increase in the preload, the same point N, it moves upward. Say this we name as N1. So, it shows that when the preload is increased, the heart pumps out more blood. Similarly, the opposite, if the preload is decreased, say at a point this, which we name as N2. So here we can see when the preload is decreased, then there is, when the preload is decreased, then there is decrease in the stroke volume, decrease in the cardiac output. So if we join this line and present it as dotted line, like the first one, the first line here to here at point N at a certain preload, the heart pumps out certain amount of blood, which we call as the stroke volume and the cardiac output. This is the case 1. Now, second case, as we have seen, second case at point N1 means when the heart is acting at the point N1. What is the situation? The situation here is increase in the preload. So here you see, from here the increase in the preload has happened. So if we draw this dotted line, we show the increase in the preload, that is increase in the preload. So at a point N1, the heart pump out more amount of blood to the periphery as well as to the pulmonary circulation. But one thing we must notice, the point has deviated from N, but it is still lying on the same curve, meaning what? This is following the Frank-Starling law. Okay, next case. At point N1, when the preload is increased, the heart is increasing stroke volume and cardiac output. Now, case 3, as we see at point N2. So, what happens in point N2? Say this is a decrease in the preload. This is a decrease in the preload. So, when there is a decrease in the preload, the amount of the blood that is being pumped decreases. So if we draw the line, we see that the amount of the blood that is being pumped out decreases. So it adds end to the decrease in preload, heart is decreasing the stroke volume and cardiac output. This is one way how we connect or correlate to the Starling curve. But this is not only one way how the Starling curve is like affecting, means the normal point is going up and down. Other factors affecting the Starling curve. Now, what are the other factors that are affecting the Starling curve? Other factor is agents or situation or condition that increases the contractility. Okay, again, let us draw the graph. So, if we draw the graph, the same Starling graph, here we have the end diastolic volume or the preload on our x-axis, and on our y-axis we again draw the cardiac output and the stroke volume. So first is our normal curve as we have it, the normal one. Now second condition is like whenever there is increase in the contractility. So whenever there is increase in the contractility, this is due to increase in the contractility we see the same curve with the same point N, with the same point N has increased its force of contraction. So, if agents like catecholamines, example epinephrine, is administered, then the Starling curve moves upward due to increase in contractility. So, increase in contractility, what it will do? It will increase the stimulate, and also it will increase the stroke volume and ultimately the cardiac output. This is also another way that how the Starling curve is moved. Okay. Second condition, suppose there is a condition in which there has been vasodilator which has been administered. Then the same curve moves like down. The same curve moves down, though the point remains to be along the perpendicular line. That means the normal point at which or from which the heart is undergoing the mechanical function, exerting force, that has not changed. Only the force of contraction has increased or decreased, but there has been no extra load on the heart to increase its work done. So here the contractility is decreased. Now, for example, if substance like antagonist to adrenergic receptors is administered, then the Starling curve moves down. That is, decrease in contractility, which will decrease the stroke volume and cardiac output. Now, this pattern in which there is increase in the contractility and the Starling curve has moved up, if you remember, yesterday through the loop, we also seen that increase in the contractility is equal to decrease in the afterload, is equal to decrease in the afterload. Example exercise. Like when a person is exercising, the force of contraction is also increasing and the afterload, means the peripheral resistance, is also decreasing. Similarly, the point that we have seen here, like same point. Okay, for our understanding, the benefit, let us say it N2 and let us call it as N1. So here you can see at N2 point, decrease in the contractility or increase in the afterload. This both decreases the contractility and the amount of the blood that is pumped to the periphery. So by this two curve, the first line that we started with, that increase in preload increases the heart to pump more blood, and increase in contractility also makes the heart pump more blood, and opposite vice versa. This is the proof of it. This curve actually proves that one. Now, a condition when both the contractility and the afterload decreases, means contractility decreases and afterload increases, is example is heart disease, hypertension. These are like the common example. Now, in case of cardiac failure, heart failure, what actually happens? In case of cardiac failure, this normal curve, this normal one, and it actually becomes much lower. It actually becomes much lower. Not only it becomes much lower, the point also gets deviated. Like the points, it goes like much higher on the scale. So you see, it is no more, if you draw the perpendicular line, it is no more aligning with the N1 and N2, which are not clinical condition. So in case of heart failure, what happens? A new foci, not a foci, a new area, a new point on the Starling curve develops, which is higher than the normal point curve. Meaning what? In a failing heart, there is ventricular remodeling, which is pathological. Meaning what? Meaning is that when the ventricle sees that too much of blood is getting accumulated and it is not having enough force of contraction to pump it out, then it tries to do a harder work. It tries to do a harder work. It does not understand that if it changes its normal course, then it can lead into a total heart failure. That the cardiac muscle don't understand. So what it feels is that the preload is more, whereas the heart is, the force of contraction is less. So I must work more forcefully so that I can contract more forcefully. So in doing that, the workload increases and the point shifts from N to N3, which makes the heart do a tougher job. So this is called ventricular remodeling, which is pathological. Now here what happens, usually what did we study? Here, like digoxin, if administered, raises the curve, raises the Starling curve. So here if digoxin is administered, what actually happen? The Starling digoxin effect. The Starling curve is raised. Raised from where? Raised from the one that was due to the heart failure. But it does not raise it back to N. It cannot raise it back to N. And the normal pumping capacity is not attained, though the failing heart is stopped from going into failure. But it cannot restore the normal curve back. Okay, it cannot restore the normal curve back. Okay, this is the curves that we have to remember. First, we studied how the increase and decrease in the preload it affects without any pathological condition, and here this is how it affects when the points are deviated. Like when the contractility is increased or decreased, still the pumping capacity is affected, though the workload is not increased. But in case of a failing heart, the workload is increased, as we see in the point N3, and decoxin raises it but do not restore it back to the normal curve. So this is the implication, the principle and the implication of the Starling curve, which we use in the medicine. Okay, this was our Starling curve. Now, moving on to the arterial blood pressure. Arterial blood pressure. We know that the arteries, the blood vessels in our body, they are in parallel orientation, right? Okay, some are in series, but mostly it is in parallel orientation. The branches of the aorta that branches out and supplies to each and every system, they lie as parallel, in parallel orientation. Some are in series, but mostly it is in parallel orientation. And the blood is flowing through them. Now, arterial pressure, this is the, this, this is the pressure exerted by the blood laterally. Okay, this is important. How does it exert? It exerts laterally. Okay, on on the walls of the blood vessel. This is what is the arterial blood pressure. Now we all know the unit to measure is mmHg. Okay, this is a unit to measure the arterial blood pressure. Why? Because this is in the column form. This is in the column form that is exerted by the mercury, and the fluctuations of the mercury, we see how it is, like how, which is a reading on the of the mercury column, and then we take it in mmHg. Now, what are the various methods to measure the blood pressure? Methods to sorry, measure the blood pressure. These days, there are many ways to measure blood pressure. Okay. Firstly, when it evolved, there was one invasive method which was painful and it became soon obsolete. Then evolved the non-invasive method. The non-invasive method is by sphygmomanometer. Now, this sphygmomanometer, they are of multiple types. The most common one is the mercury sphygmomanometer. Now, there is like this aneroid. Then there is the hybrid also. Now, among all these things, mercury sphygmomanometer is still widely used, right? So, on what principle within the body does it work? Principle is the brachial artery is occluded by cuffing, means by usage of a cuff. Okay, cuff-like structure, this brachial artery is occluded. Okay, and a stethoscope is used to hear or auscultate the pulsatile blood flow. So this is a principle on which the sphygmomanometer works. Okay. Now, the audible sounds, the audible sounds are of like 5 types. Okay. So they are of like 5 types in 5 phases. In phase 1, the sound is tapping type. The first auscultation sound that we hear, the type is like a tapping sound. It's like a tap sound. Okay. In the phase 2, the sound becomes softer and longer. In the phase 3, the sound becomes crispier and louder. In phase 4, the sound becomes muffled. And phase 5, the sound becomes inaudible. Means the sound stops. Totally it stops. Now, the sound over and over that we were talking, what is the terminology that is used for the sound? There's a particular terminology that is used to refer to the sound. The sound is called as Korotkoff sound. The sound that we are talking about is called the Korotkoff sound. But there is a importance or significance of the sound. What is that? The first audible sound, that is phase 1, marks the systolic blood pressure and the phase 5, that is disappearance of the sound, that is a Korotkoff sound, marks the diastolic blood pressure. Okay. Usually systolic blood pressure is about 120 mmHg and diastolic blood pressure is about 80 mmHg. And do remember, when we have a standard value in physiology, what did we study right at the beginning? It is implied that the person is healthy and is a healthy adult and is of 70 kgs of weight. But of course, depending on a person's stature, sex, age, physiological condition, leave out the pathological condition, there will always be a difference in the normal systolic blood pressure and diastolic blood pressure among person, like a person to person, which is not at all abnormal, provided there is no pathological condition. Okay. Now, there is a implication. What is the applied part of it? What is the applied part of the auscultation? In older person or in pathological condition, we get auscultatory gap. We get auscultatory gap. Now, what is the auscultatory gap? This auscultatory gap, what does it mean? Here, the auscultatory gap, it is the disappearance of sound between the systolic blood pressure and diastolic blood pressure. So, sometime it may happen that there is like one sound and then after that there is no audible sound at all. So, in such cases, the person is told to raise the hand above the head and keep for 30 seconds. The person is asked to lift the hand above the head for 30 seconds. Why it is done? If it is kept above the head for 30 seconds, the blood circulation increases and then again the auscultation is checked. This auscultatory gap is very common in older people. So, auscultatory gap increases with age and the systolic blood pressure and diastolic blood pressure values becomes wrong. Okay, this is the implied part of it. Now, coming to the arterial blood pressure, there are like different types of the blood pressure. So, what are the types of the arterial blood pressure? The different types of the arterial blood pressure and what are they? One we already studied, that is the systolic blood pressure. The systolic blood pressure is about 120 mmHg. Now this is directly proportional to the stroke volume. So, if stroke volume is more, then the systolic blood pressure will also be more, directly proportional to the stroke volume. So if stroke volume is more, then the systolic blood pressure will also be more. Systolic blood pressure is inversely proportional to the compliance of aorta. It is inversely proportional to the compliance of aorta, directly to the systolic blood pressure. It is directly proportional to the like stroke volume, and indirectly or inversely to the stroke volume. Let me just direct. So what does this compliance of aorta mean? Say this is the aorta. Okay. Aorta, we know this is a Wien-Kessel vessel. This aorta, it is a Wien-Kessel vessel. So whenever there is blood flowing through the aorta. So this is, for example, say this is the blood that is going to the aorta. Okay, it is going to the aorta. Now, when the blood is entering in large quantity or in more volume, the aorta, it has a capacity to stretch out. The blood, it cannot actually exert a lot of pressure on the walls of the aorta because it has got smooth muscle, it has got elastic fiber. So when big or large amount of blood is entering the aorta, the pressure kind of cannot exert very high on this aortic blood vessel because the aorta expands, it gets stretched. So it becomes something like this. With the incoming of large quantity of the blood, it stretches out. The aorta stretches out. So the capacity to distend, the capacity to stretch out whenever there is like incoming of blood or whenever there is like exertion of pressure, this is called the compliance. This is called the stretchability under pressure, which is the compliance. So, if the stretchability or the compliance of aorta is high, then or more, then the systolic blood pressure will be less because the pressure is getting equally dissipated on the walls of the aorta. It is not able to exert high pressure. So if the stretchability of aorta is more, the systolic blood pressure will be less. This is one of the reasons why if there is any elastic fiber loss to the aorta, to the coronary artery, then the blood pressure increases, which we call as the hypertension. Okay, this is our systolic blood pressure. Now, second factor, second blood pressure, which is the diastolic blood pressure. Now, this is the pressure. This pressure, this is the pressure faced during the pumping of blood. Okay. Now, the factors that affect diastolic blood pressure is directly proportional to the total peripheral resistance. So, if due to any reason there is increase in the total peripheral resistance in the periphery, like some arteries may be blocked or some arteries due to some age-related issues or pathological condition, the elastic tissue has weared out and it has become hard, then the heart will face more difficulty in pumping out because there will be increase in the total peripheral resistance, which is also the afterload, right? Now, diastolic blood pressure is equal to 80 mmHg in an adult physiologically normal who's 70 kgs of weight. The third one is the pulse pressure. This pulse pressure, it is actually systolic blood pressure minus the diastolic blood pressure. Automatically we know 120, assuming it's 120 and 80, it is about 40 mmHg. So this pulse pressure is usually between 30 to 40 mmHg. Now, this pulse pressure is a good reader of hypertension or rather systemic hypertension. So, it is calculated as the formula is 2/3 of diastolic blood pressure plus 1/3 of systolic blood pressure is what gives the pulse pressure. So, if in a person the pulse pressure is about 90 to 100 mmHg, then it indicates hypertension and it may cause damage to organs, like it gives damage to organs like the brain, kidney and liver. Okay. Now, next pressure that we are concerned about, it is the mean arterial pressure. Mean arterial pressure. Now, this is the formula that we wrote just above the pulse pressure, because pulse pressure relates to the mean arterial pressure. Now, mean arterial pressure, it is about 90 to 100 mmHg. Now, what is the implication of it? This is the pressure that is maintained during cardiac cycle. That's why the formula is actually the systolic blood pressure plus like 1/3 of pulse pressure. So if we compute that one, we get the mean arterial pressure to be this one, Okay. Now, this is actually this mean arterial pressure is directly affected by the total peripheral resistance. So if there is any resistance in the periphery, any blockage in the artery or any kind of problem in the peripheral resistance, this mean arterial pressure will be affected, and it will also affect the perfusion to the different organs. So if mean arterial pressure is low, then the then the blood perfusion to the organs will be inefficient. Okay, and to mean arterial pressure, to mean arterial pressure, the arterioles, which is the resistant vessels, offer maximum resistance. Okay, so these are the important characteristics of the arterial blood pressure, the types, their implication, their values, and what do they. Okay, now one applied part of this mean arterial pressure is one applied implication is in carotid sinus syndrome. Okay, carotid sinus syndrome. Now, what is this carotid sinus syndrome? If the carotid artery is pressurized externally, then the blood flow decreases, which may result in syncope, which means fainting of a person. So this is also a reason why some people just faint if they wear a very tight collar. If a tight collar pressurizes the carotid artery, then the person may faint. Okay, this is one thing. Secondly, this phenomena, like if the carotid artery is pressurized, then there is a like a temporary drop in the pressure and the person may faint. This principle is also used to treat a weak lock. Okay, so these are the implied or applied implications in context to the clinic. Now we come to the important part of the lecture. Everything is important, but this is like something which is very high yield and you cannot afford to forget. These are the regulation of arterial blood pressure. This is very, very important. This concept, the concept that we are going to build here, this is very, very important because this is something that happens every day, daily in our life. Okay. Now, regulation of the blood pressure, regulation of blood pressure. It is of two type. Two type. After regulation of blood pressure, we will also see the effect of position on the blood pressure. This should lay a very good concept about the arterial blood pressure for us. Now, regulation of blood pressure, it is of two type. Primarily two types, which is the short term regulation. Another one is the long term regulation. Now, short term regulation of the blood pressure. We have discussed about it in the homeostasis. If you remember, there we did mention about a receptor reflex, which is the baroreceptor reflex or baroreflex. Short term means the correction of the blood pressure happens very fast, but this correction lasts only for a small period of time. Say, for example, a person is working out on a treadmill initial days. I'm not talking about the adjustment after a long time. So initially, when the person is working out on a treadmill, or the person wakes up in the morning and is started running or regular activity of the day, what happens? The blood pressure increases. But that increase does not make us rush to the hospital. We are not hospitalized or sick, because immediately it is the baroreflex that comes to the help and brings the blood pressure back to the normal. The long-term correction usually happens after a disease, after a traumatic condition, when some medication has to be administered. So, like, it is called the permanent correction of the blood pressure. Now, this happens via RAS system, renin, angiotensin, aldosterone system, and additionally there are other two like biomolecules also, nucleotides and peptidases also, that helps in it, that we will come. Now, coming to the short term regulation. So, short term regulation or baroreflex. On what principle does this short term regulation work? The principle here is increase in the blood pressure, okay, causes decrease in the blood pressure. So whenever there is increase in the blood pressure, it immediately causes decrease in the blood pressure. And what is it? This is an example of negative feedback mechanism. So anything that causes increase in the blood pressure immediately causes decrease in the blood pressure. Now, this whole method, the whole system, like the increases cause the decrease, it has a cascade of components. Okay. The components involved here are, how does the process happens, and with the component, the process and components. Okay, we'll study side by side so that we can correlate to that one. So, increase in the blood pressure. Whenever there is increase in the blood pressure, what will happen? It will be sensed by the baroreceptors or stretch receptor. Now, here comes what are the baroreceptors or the stretch receptors. So, let's talk about it. Baroreceptors or the stretch receptors. So, I'm writing it here. So, what are the baroreceptors? Baroreceptors, these are like, there is arc of aorta. This is the arc of aorta. Okay, and there is this dilation in the carotid artery. The common carotid artery bifurcates into left and right, right? So this dilation is called the carotid sinus. Okay, so this arch of aorta, this arc or arch of aorta plus the carotid sinus, they make the baroreceptors. Means whenever there is inflow of the blood, whenever like blood is flowing through them, whenever the blood is flowing through them, the substances like the structures, these components, these are the components, then they can sense it. They can sense the change in the pressure. More blood flow means more pressure. More blood flow means more pressure. This will be sensed by the baroreceptor and the stretch receptor. So this is our baroreceptor and the stretch receptor. Clear? Now, after sensing it, what will happen? This receptor, what it will do? Will send afferents. Will send afferents to the medulla. Medulla where? In the nucleus of tractus solitarius. Okay. Now, this sending of this information, afferents means afferent has to be via the nerve fiber. In the nerve fiber, what did we study? Some nerve fiber carries the impulse, some nerve fiber brings back the impulse from the CNS. So, this one will be sent that there has been stretching, increase in the blood pressure. This one will be sent to the medulla in the center, that is called the tractus of nucleus of solitarius. Now, this afferent will be sent by the two nerve that is innervating the carotid arch and the carotid sinus and the arch of aorta via 10th and 9th cranial nerve. Okay. Now here, this carotid sinus, it is innervated by the 10th cranial nerve, that is the vagus. Whereas the arch of aorta, it is innervated by the glossopharyngeal, that is the 9th cranial nerve. Now, in context to this one, what we have to remember? Point to be remembered is that the 9th cranial nerve is the glossopharyngeal nerve and 10th is the vagus nerve. Now, ninth and 10th nerve are called buffer nerve or scion nerve or sinoaortic nerve. These are so many names of this nerve. So, this efferent are sent to the nucleus of tractus solitarius in the medulla. Now, when this nucleus of tractus solitarius sees that there has been increase in the pressure. Now, increase in the pressure has to do what? Increase in the pressure has to do the decrease in the pressure. So, what it will do? This one, it will inhibit the sympathetic nervous system, and it will stimulate the parasympathetic nervous system. Okay. Now, what the sympathetic nervous system and parasympathetic nervous system will do? The sympathetic nervous system this one through the centers in the, via the NTS center, it will inhibit the heart, the blood vessels. Okay, it will inhibit the heart and the blood vessels. And here, via again the nucleus of rectus solitarius, here actually nucleus of ambiguous, what it will do? It will cause the release of glutamate, which is inhibitory neuron. Now, which is stimulatory excitatory neuron, which is excitatory neuron. Now, this glutamate, what it will do? It will stimulate the caudal ventrolateral nucleus of the medulla, the caudal lateroventral nucleus of the medulla. Now, its function is to inhibit the pressure activity. Pressure activity means increase in the heart rate, increase in the contractility, increase in the excitability. Now, this caudal ventrolateral medulla, that side, it will secrete GABA. Now, GABA is an inhibitory neurotransmitter. This one will inhibit the rostral ventrolateral medulla. Now, what is the function of this rostral ventrolateral medulla? It carries out pressure activity. Okay. Now, when this happens, again, via the parasympathetic nerve route, it will once again, it will inhibit the SA node and it will inhibit the blood vessel. Okay. So, if we see it again, what did we see? Increase in the blood pressure decreases the blood pressure. Now, there is a component and the structures involved in it. Like whenever there is increase in the blood pressure, it will send out signal. And who will sense it? The sensor are the baroreceptor or the stretch receptor. Which is a baroreceptor or the stretch receptor? On our right, we have seen these are the arch of aorta and the dilation, the carotid sinus. Okay, this is the baroreceptor. Now, what it will do? This baroreceptor, the carotid sinus, it has got innervation from the vagus nerve, 10th cranial nerve, and the arch of aorta, it has got innervation from the glossopharyngeal, that is the cranial nerve number 9. So, this afferent will be carried out to the medulla. Now, medulla will say, okay, the information is such that the blood pressure has increased. Now, it will stimulate the center that will cause the decrease of the blood pressure. So, here you see the sympathetic nervous system will be decreased because sympathetic nervous system increases everything, and parasympathetic nervous system will be stimulated because it decreases the function of the heart. We have studied that already. So, when the sympathetic nervous system is inhibited, heart rate will go down, negative chronotrophy, and also the blood vessel will be dilated. The blood vessels will dilate. It will not constrict. Simultaneously, the parasympathetic nervous system will be stimulated. So, this one via another center, nucleus of ambiguous, it will secrete glutamate, which is an excitatory neurotransmitter. Now, this glutamate will stimulate the caudal ventrolateral medulla, which is a deep pressure area. Means it decreases the cardiac function. Negative chronotropy, negative inotropy, negative bathmotropy, dromotropy, all these things are by the stimulation to the caudal ventrolateral medulla. Now, this caudal ventrolateral medulla, now it will secrete GABA, inhibitory neurotransmitter. Now, GABA will will make the rostral ventrolateral medulla quiet. Rostral ventrolateral quiet means it is the area for increasing the cardiac function, like the contractility, the constriction of the blood vessel, the SA node, all these things, it will function more if the rostral part is stimulated. So, caudal part via the GABA, it will quieten or inhibit the rostral part. So, as a result of which, there will be additional inhibition to the SA node, which will just now give out the autorhythmicity at a very slow pace because the blood pressure has gone up, it has to be brought down, and also the blood vessel will be dilated. And not only that, there will be also inhibition to the contractility. So all this thing together will bring down the blood pressure. Now, one thing, if you see here, what is the takeaway from it? What additionally we have to remember? The increase in the blood pressure has caused decrease in the blood pressure. So, decrease in the blood pressure means what? Inhibition to the sympathetic nervous system. Okay, that means only sympathetic nervous system, if it is inhibited, then there will be decrease to the blood pressure. Now, inhibition of the sympathetic nervous system means what? Inhibition to the SA node. Inhibition to the SA node means what? Decrease in the heart rate. Decrease in the heart rate. So, what does it stand? It stands out to be, if we connect this point to this point, if we connect this point to this point, what does it stand? It stands out to be increase in blood pressure, decreases heart rate, or we can also write that blood pressure is inversely related to the heart rate. So, if the blood pressure is more, the heart rate will be less. This is what we can write. Now, this whole thing is called as Mary's law. This is what is the Mary's law. So, whenever there is increase in the blood pressure, Mary's law comes to work. Okay, this is the short-term regulation of the blood pressure. Coming to the long-term regulation. Now, what is the long-term regulation? Long-term regulation of the blood pressure is always via the hormones. So, it is the hormonal correction of the blood pressure. So, what happens? We know there are these stretch receptor present. Where they are present, we know. So, increase in the blood pressure, what does it do? It brings out prorenin and converts into renin in blood. Prorenin, where is the prorenin? It is staying in the kidneys. It brings out the prorenin and in the blood it converts it into renin. So, when it is converted into renin, this renin, it will act on the angiotensin and it will convert it to angiotensin. Okay. Now, this angiotensin, it will be changed to angiotensin 1 in the first form, and then in lungs and kidney it will be converted to angiotensin 2. Now, angiotensin, this all are like vasoconstrictor, but angiotensin is like 10 amino acid long and angiotensin 2 is 8 amino acid long, and this is the most potent vasoconstrictor. Now, this angiotensin, it will again after 1 to 2 minutes, it will immediately change into angiotensin 3 and 4. Okay. Now, this angiotensin 2, okay, now from 1 to angiotensin 2, the enzyme that changed it is the angiotensin converting enzyme. Okay. And angiotensinogenase, it converted angiotensinogen to angiotensin. Okay. So, angiotensino, writing the name of the enzymes are very important, because to treat any cardiac function or correct the blood pressure, this receptor targets and the enzymes are very active site for the drug to act on. Now, this angiotensin 2, it has got receptor in the brain, it has got receptor in the kidneys, it has got receptor in the adrenal cortex, it has got receptor everywhere. So, it will now, what it will do, it will have multiple function. In the brain, in hypothalamus, in the brain, in the hypothalamus, what it will do? It will induce thirst. It will make the person thirsty, as a result of which there will be consumption of water and there will be blood volume change. Okay. Now, when the blood pressure is more, that means what? That means what? The blood volume is already more. The blood volume is already expanded, right? So, when this is more, then the stimulation to the renin, will be inhibited. I repeat, when the blood pressure is high, the following reactions will be inhibited. Okay. Now, angiotensin 2, what it does? On the brain, it induces thirst. It will act on the kidney and it will cause natriuresis. It will cause natriuresis, means sodium and water both will be lost in the urine in large quantity. and the level of adrenal cortex, it will induce release of aldosterone. Now this aldosterone, it will act on renal system or kidneys, and what it will do? It will increase reabsorption. It will increase the reabsorption of water and mineral. Okay, this is what is the function of the angiotensin 2. Now, in case of high blood pressure, when BP increases, then this reaction will be inhibited. This reaction will be inhibited inside the body. Now, to treat chronic high pressure, drugs are designed to target the angiotensin converting enzyme and angiotensin 2 receptors and are combined with vasodilator. Okay, are combined with vasodilator. So, to treat hypertension, angiotensin 2 receptors are targeted, angiotensin converting enzyme is like inhibited, and it is combined with vasodilators. Okay. This is how the long-term regulation happens in case the blood pressure is increased. In case if the now this the whole system is the renin-angiotensin system of the RAS system. So what we understood was like inhibition of the RAS if the blood pressure is increased. Now, if blood pressure decreases, then RAS is stimulated. Now, one clinical implication in context to the short-term regulation, okay, which needs a mention. One clinical implication of baroreceptor. Okay, so the pressure at which the baroreflex acts best is between 70 to 170 mmHg. Since it is receptor based, there is always a range at which this reflex works. So if we draw the diagram like in a graph form, say this is like pressure scale, and this is like the maximum efficiency scale of the baroreflex, and say this is like 100. This is the midpoint, which is 100 mmHg. It is seen that, and this is like 70, and this is like 200. So 170 will be something like. So it is seen that the region, the area or the range at which it acts best is something like that. The curve stands out to be something like this with its maximum efficacy lying across this dotted line. So the range here at which it acts maximum is 170, like 70 to 170 mmHg. Now, in case of chronic hypertension, if a person is constantly suffering from hypertension and it is not getting corrected, this a new curve, a new range is attained. Like this curve shifts towards the right. It shifts towards the right and the range changes from like to more than 100 to 200. So, in chronic hypertension, the range changes to 100 to 200 mmHg, and when the heart has to pump, the ventricle has to pump blood under such high pressure, it is detrimental for the ventricular function, for the pumping of the ventricle. If the baroreceptor innervation is damaged, okay, if there is any damage to the baroreceptor or its innervation, then the baroreceptor cannot sense the hypertension. Now, this is a condition which is called as neurogenic hypertension. Okay, so this was our short-term and long-term regulation of the arterial blood pressure. Now, coming to the last part of today's session, the effect of change in position on the arterial blood pressure. Now, what is a change of position in the arterial blood pressure? The first case, the first scenario, when a person lies down from standing position. This is our first change in the position. Like a person was like standing, all of a sudden he sits and then he lies down. What will happen to the arterial blood pressure and how will it get corrected, changed, or what is happening? So, when the person is standing, when the person is erect, like standing, okay, blood is more in the lower extremity, in the lower extremities. Like there is a lot of blood that is in the veins of the leg because of the gravitational pull. Because of the gravitational pull. So, there is venous pooling. pull, like the veins will have lot of blood because the legs are touched to the gravity. The force of gravity is there and the blood is more, a lot of blood is stationed in the vein. Okay. Now, when lies down, then the venous return increases. The person was erect, now lying down in the sleeping position. So the venous return has increased to the heart. Not only venous return, there is increase in the central venous pressure. Central venous pressure, that is pressure in inferior and superior vena cavas, right? There is increase in the central venous pressure. So when there is increase in the central venous pressure, what is the scenario? There is increase in the arterial blood pressure. So when there is increase in the arterial blood pressure, it should not be allowed to go, right? So immediately the barrow reflex will come. So barrow reflex acts. How does it act? It will stimulate, means it will stimulate the nucleus of tractus solitarius via the buffer nerves. That is our ninth nerve and 10th nerve. Now this one, what it will do? It will stimulate the deaccelerator center in the heart, right? That is the parasympathetic nervous system, and it will inhibit the accelerator system in the heart. That is the sympathetic nervous system. So when this is happening, the parasympathetic and the sympathetic nervous system, this parasympathetic nervous system, what it will do? It will decrease the heart rate, decrease the contractility, okay? And here it will decrease the, or rather instead of decrease, it will cause inhibition of the sympathetic nervous system, will cause vasodilation and will also decrease the heart rate. So together this decrease, what it will do? It will ultimately decrease the blood pressure back to normal. So when a person was standing, when the person was erect and he lies, what happens? Venous return increases, the pressure in the vena cavas increases, the blood that is going to the heart increases because now he is lying down. The blood is no more pulled in the veins. So the deaccelerator system is like stimulated and accelerator system is inhibited and it is decreased back to normal. The blood pressure is decreased back to normal. Now, if the position is changed, like our scenario B, when a person stands up from lying position, okay? When a person is standing up from a lying position, was lying, all of a sudden stood up, okay? So here, first what happens? Here, the venous return decreases. Why the venous return decreases? Because blood flows to the extremities. When the person is standing, again the feet are touching the ground, there is force of gravitation and the blood goes more to the leg. So there is more staying of the blood in the vein. So increase in the venous pooling. Okay. Decrease in venous return. Again I am writing, and decrease in the central venous pressure. So when there is a decrease in the central venous pressure, then what will do? Via the buffer or sinoaortic nerve, buffer nerves, what happens? Once again, the nucleus of tractus solitarius gets stimulated. Now, what will it see? It will see that the opposite has happened. The blood pressure has gone down. So, it will sense drop in blood pressure. It will sense drop in blood pressure due to the drop in the venous return and the central venous pressure. So once there is drop in the blood pressure, just opposite will happen. What it will do? It will stimulate the sympathetic nervous system and it will inhibit the peripheral nervous system. Sympathetic nervous system we have written, that is accelerator process, accelerator component, and parasympathetic is a decelerator. So here it will increase, it will stimulate the SA node, it will increase the contractility, and it will increase the peripheral resistance leading to vasoconstriction. Due to vasoconstriction, there will be increase in the total peripheral resistance. And since there is inhibition to the this parasympathetic nervous system, what will happen? What will happen? There will be indirectly again stimulation to the SA node and stimulation to the contractility. As a result of which there will be increase in heart rate, and here also there will be increase in the heart rate. So heart rate increased means increase in stroke volume, increase in stroke volume. Now both this two, it will increase the blood pressure back to normal. Okay, this is how the position affects the blood pressure. Now there are two other substances other than the short term and long term, other biological molecules that also help in the correction of blood pressure, high blood pressure, like two other peptides rather. Two other peptides that participates in the long term correction of blood pressure. Now, what are those two? The first one is the ANP, atrial natriuretic peptide. Now, its first thing is that it works opposite to the RAS system. It works counterly, like opposite to RAA system. How does it do? So this ANP is released when the atrial myocytes are stretched. So whenever there is increase in the blood pressure and the atrial myocytes are stretched, this ANP is released. Now, this ANP, it acts on multiple structures. Like it ANP. First, it acts on the kidneys. It acts on the kidneys. It will increase the glomerular filtration rate and it will increase the diuresis. So like that, extra volume of fluid is excreted out of the body. On the heart, on the heart, the way it acts is that it immediately decreases the venous return by decreasing the venous return, it decreases the central venous pressure. So when there is decrease in the central venous pressure, there is automatically decrease in the blood pressure. Okay. Another way it acts is that it inhibits the aldosterone. So once it inhibits the aldosterone, the water and mineral absorption is inhibited. Okay. Now, this ANP, it cannot stay in the system for a very long time. There is a this neuropeptidase, like there is a neural endopeptidase. This short form is NEP. This NEP, which is an endopeptidase, it digests the atrial natriuretic peptide in the circulation. So, okay. So now this ANP, what is its implication? Its implication or importance is that this ANP is become, it is become, not has, it is become the drug target along with vasodilator and receptor inhibitors to treat hypertension. Okay, this is one molecule. The another one, which is also very effective, is the brain derived natriuretic peptide. Now, this is secreted by the ventricles when the ventricle healing becomes more. That is the end diastolic volume or preload increase. Its function is same, more or less. its its function is same as that of A and B. So what is the advantage of it? The advantage of it is that there are there are no endopeptidases that can digest the brain-derived natriuretic peptide. Okay, so this was all about our regulation of the arterial blood pressure. The short term, the long term. Before that, we started with the Starling curve. Hope this video is helpful to you. Thank you.